Welcome back, everyone. Today, we start a new chapter in Toronto Notes 2025, the Pharmacology. In this lecture, we will discuss the general principles of pharmacology. Now, let's start the drug nomenclature. Before a medication reaches the patient, it is assigned several different names and identification numbers, each serving a unique purpose. First, let's discuss the Drug Identification Number, or DIN. In Canada, every medication approved by Health Canada is assigned a unique Drug Identification Number, or DIN. This number confirms that the drug has been evaluated for its safety, efficacy, and quality. In the United States, the equivalent system is known as the National Drug Code, or NDC, assigned by the Food and Drug Administration, or FDA. For homeopathic products registered in Canada, a DIN HM is assigned instead of a regular DIN. This specifically identifies licensed homeopathic medicines. Another important identifier is the Natural Product Number, or NPN. This number is assigned to natural health products such as vitamins, herbal remedies, and mineral supplements. These products are regulated by the Natural and Non-Prescription Health Products Directorate of Health Canada and do not include homeopathic medicines. Next is the chemical name. This is the scientific name that describes the exact chemical structure of the drug according to the International Union of Pure and Applied Chemistry, or IUPAC. For example, the chemical name for N4-hydroxyphenylacetamide refers to medication commonly known as acetaminophen. Chemical names are universal, but are often too long and complex for routine clinical use. The non-proprietary name, also called the generic name, is the international accepted name approved by official nomenclature committees. This is the name commonly used in medical practice, prescriptions, and pharmacology textbooks. Drugs belonging to the same class often share similar suffixes. For example, atorvastatin, simvastatin, and paravastatin all belong to the statin class because they end in statin. Finally, the proprietary name, also known as the trade or brand name, is the name chosen by the pharmaceutical manufacturers. An example is Lipitor, which is the brand name for atorvastatin. Unlike generic names, brand names may differ between countries and manufacturers. Understanding these different naming systems help healthcare professionals accurately identify medications and avoid prescribing errors. Phases of clinical drug testing. Before a drug becomes available for patient use, it undergoes a series of careful regulated clinical testing phase. The process begins with the preclinical phase. During this stage, the drug is tested in laboratory cells, tissues, isolated organs, and animals. Researchers evaluate its pharmacokinetics, which describes how the body absorbs, distributes, metabolizes, and eliminates the drug. They also study pharmacodynamics, or how the drug affects the body while identifying potential toxicities before human exposure. Following successful preclinical testing, the drug enters phase 1 clinical trials. This is the first time the medication is administered to humans. Typically, A small group of healthy volunteers participate in these studies. The primary objectives are to evaluate the drug's safety, determine its pharmacokinetics, and establish an appropriate dosage range. Next is phase 2, where the drug is administered to a relatively small number of patients who actually have the disease being treated. Researchers focus on determining the drug's efficacy while continuing to monitor safety, identify the optimal dosage, and further evaluate pharmacokinetics. The drug then progresses to phase 3 clinical trials. These are large-scale randomized controlled trials involving hundreds or even thousands of patients. The new medication is compared with either a placebo or a current standard treatment. These studies are usually double-blinded, meaning neither the patients nor the investigators know who receives the experimental drug. Phase 3 trials provide the evidence needed to establish the drug's safety and effectiveness before regulatory approval. Even after approval, drug evaluation continues through phase 4, also called post-marketing surveillance. Once the medication is widely used in the general population, researchers monitor its real-world effectiveness, detect rare or long-term adverse drug reactions, and identify safety concerns that may not have appeared during earlier clinical trials. Remember the progression: preclinical, laboratory, and animal testing. Phase 1, safety in healthy volunteers. Phase 2, efficacy and dosing in patients. Phase 3, large randomized clinical trials comparing treatments. Phase 4, long-term monitoring after approval. Drug administration. The final section discusses the principle of the drug administration. Selecting the appropriate route of administration depends on several important factors. The first consideration is the available formulation. Some medications are available only as oral tablets, while others may also be administered intravenously, intramuscularly, subcutaneously, inhaled, or typically. The desired local or systemic effect also influences route selection. For example, topical creams provide localized treatment with minimal system absorption, whereas intravenous administration delivers the drug directly into the bloodstream for rapid systemic effects. Another factor is the desired onset and duration of action. Intravenous medication produce immediate effects, making them ideal in emergencies, while oral medications generally have a slower onset but are more convenient for long-term treatments. Patient's adherence is equally important. Simpler dosing schedule and convenient administration routes improve compliance. For example, once daily oral therapy is generally preferred over multiple daily injections whenever appropriate. Finally, patient-specific characteristics such as age, swallowing ability, gastrointestinal function, kidney and liver disease, level of consciousness, and clinical condition all influence the safest and most effective route of drug administration. To summarize this page, drugs have multiple identifiers including DIN, DINHM, NPN, chemical name, generic name, and trade name. Drug development progresses through preclinical studies followed by phase 1 through 4 to establish safety, efficacy, dosage, and long-term monitoring. Choosing the correct route of a drug administration depends on the drug formulation, desired therapeutic effects, onset and duration of action, patient's adherence, and individual patient's characteristics. Understanding these principles provides the essential framework for safe prescribing, rational drug development, and effective pharmacotherapy. Now let's move on to the next page. Let's begin with Table 1, Routes of Drug Administration. The first and most commonly used route is the oral or PO route. Oral administration is preferred because it is convenient, easy for patients to take, and relatively inexpensive compared to injectable medications. The gastrointestinal tract provides a large surface area for drug absorption, making this route suitable for many medications. However, oral drugs have several limitations. Their absorption may be incomplete or variable, and they undergo hepatic and intestinal first-pass metabolism, which reduces the amount of active drug reaching systemic circulation. Additionally, oral medications may interact with blood or other drugs, are influenced by the gastrointestinal motility, and require a normally functioning digestive system. The second route is the buccal or sublingual route, where medications are placed inside the cheek or underneath the tongue. This route provides a rapid onset of action because drugs are absorbed directly into the bloodstream through the oral mucosa. Importantly, it avoids first-pass metabolism, increasing bioavailability. However, only drugs that are sufficiently lipid-soluble and non-irritating are suitable for this route. A classic example is nitroglycerin, which rapidly relieves angina. Next is rectal route, commonly abbreviated as PR. Rectal administration is particularly useful for patients who are vomiting, unconscious, or unable to take medications orally. Compared with oral administration, it experiences less hepatic first-pass metabolism. Despite these advantages, rectal administration is often inconvenient for patients. Absorption can be unpredictable, local irritation may occur, and only a limited number of drugs are available in suppository form. Moving on to the intravenous or IV route. This method delivers medications directly into the bloodstream, producing immediate therapeutic effects. Since absorption is bypassed entirely, IV drugs have 100% bioavailability and do not undergo first-pass metabolism. This route is ideal for emergencies and allows precise dose titration. Nevertheless, it carries risks such as infection, bleeding, vascular injury, and extravasation. IV administration also requires sterile conditions and trained healthcare professionals, making it more expensive than oral therapy. The intramuscular or IM route. This route involves injecting medications into muscle tissue. Certain medications can be formulated as depot preparations, allowing a slow and sustained drug release over weeks or even months. Alternatively, aqua solutions may produce a rapid absorption, as seen with emergency epinephrine injections. The disadvantages include pain, hematoma formation, and the requirement for a sterile technique during administration. Another injectable route is the subcutaneous or SC route, where drugs are injected into the tissue beneath the skin. This route provides relatively constant and predictable absorption and is easier for patients to self-administer. Insulin and heparin are common examples. However, only small injection volumes can be administered. Repeated injections may cause tissue damage and mild pain at the injection site. The intrathecal route involves administering medications directly into the cerebrospinal fluid. This allows drugs to bypass the blood-brain barrier, making it particularly useful for spinal anesthesia or chemotherapy involving the central nervous system. Because it's invasive, it carries risks such as infection, cerebrospinal fluid leakage, and requires a specialized training. The inhalation route delivers medications directly into the lungs. It provides a rapid onset of action due to lungs' large surface area and rich blood supply. It is especially valuable for respiratory diseases such as asthma and chronic obstructive pulmonary disease or COPD. Furthermore, inhaled drugs largely avoid first-pass metabolism. However, inhaled medications may irritate the airways and trigger coughing. The topical route includes medications applied directly to the skin. Or mucous membrane or eyes. These medications are easy to administer and usually produce localized effects with minimal systemic absorption. Their main limitation is that their effects are generally confined on the site of application. The transdermal route involves drug absorption through the intact skin using patches. It provides continuous sustained drug delivery while avoiding hepatic first-pass metabolism. Common examples include nicotine and fentanyl patches. However, transdermal drugs typically have delayed onset of action and may cause local skin irritation. Finally, there are specialized administration routes such as intraperitoneal, intra-articular injection, which are used primarily to achieve localized therapeutic effects. Because these are invasive procedures, they carry risk of infection and hemorrhage and requires sterile techniques and trained personnel. Now, let's move to the second section of today's lecture, pharmacokinetics. Pharmacokinetics is often summarized by the phrase, what the body does to the drug. It describes the journey of a drug through the body after administration. Pharmacokinetics encompasses four major processes: absorption, distribution, metabolism, and excretion, commonly remembered by the acronym of ADME. Now we focus on the first process, absorption. Absorption is defined as the movement of a drug from its site of administration into the bloodstream. Only after reaching systemic circulation can most drugs exert their therapeutic effects. Several mechanisms allow drugs to cross biological membranes. The most common mechanism is passive diffusion, where drugs move from areas of higher concentration to areas of lower concentration without requiring energy. Because most medications are absorbed this way, passive diffusion is considered the principal mechanism of drug absorption. Other mechanisms include active transport, which requires energy and carrier proteins to move drugs against the concentration gradient. Facilitated diffusion, which also uses carrier proteins but does not require energy. And pinocytosis or phagocytosis processes mainly responsible for transporting large molecules across cell membranes. Several important factors influence the rate and extent of drug absorption. The first factor is lipophilicity or lipid solubility. Drugs that are more lipid soluble cross cell membranes much more easily because cell membranes are composed primarily of phospholipids. Therefore, lipid-soluble drugs are generally absorbed more rapidly than water-soluble drugs. The second factor is local blood flow at the site of administration. Greater blood flow removes absorbed drugs more quickly, maintaining a concentration gradient and enhancing absorption. This explains why sublingual medications produce such rapid effects, as the tissue beneath the tongue are highly vascular. The third factor is molecular size. Smaller drug molecules diffuse across membranes more easily, whereas large molecules, typically those exceeding approximately 1,000 Daltons, are poorly absorbed by passive diffusion. Another critical determinant is pH and drug ionization. Many medications are weak acids or weak bases. For example, aspirin is a weak acid, while ketoconazole is a weak base. Drug exists in both ionized or charged and non-ionized or uncharged forms. Only the non-ionized form readily crosses lipid membranes through passive diffusion. The proportion of ionized and non-ionized drugs depends on the environmental pH and the drug's pKa, a relationship explained by the Henderson-Hasselbalch equation. Another important factor is the surface area available for absorption. The small intestine contains numerous villi and microvilli that create an enormous absorptive surface area. Consequently, despite the acidic environment of the stomach, the majority of orally administered drugs are absorbed in the small intestines. Finally, drug transporters also influence absorption. Proteins such as P-glycoprotein, often abbreviated PGP, actively pump certain drugs out of cells, reducing their absorption and contributing to multi-drug resistance. In contrast, transporters such as organic anion transporting polypeptides or OATPs facilitate the uptake of specific medications into cells. To summarize this page, the choice of drug administration route determines how quickly a medication works, how much drug reaches systemic circulation, and the potential risk associated with the treatment. Oral administration is the most convenient but is affected by first-pass metabolism. Intravenous administration provides immediate action and complete bioavailability, while sublingual administration offers rapid absorption without first-pass metabolism. Pharmacokinetics describes the body's handling of a drug through the process of absorption, distribution, metabolism, and excretion. Drug absorption is influenced by lipid solubility, blood flow, molecular size, pH, surface area, and specialized transport proteins. Mastering these principles provides the foundation for understanding drug therapy, optimizing efficacy, and minimizing adverse effects. Now let's move on to the next page. We start with bioavailability, or F. Let's begin with bioavailability, represented by the F letter. Bioavailability refers to the proportion of an administered drug dose that reaches the systemic circulation unchanged and is available to produce its therapeutic effect. A drug with 100% bioavailability reaches the bloodstream completely intact. This occurs with intravenous or IV administration because the drug is injected directly into the circulation. IV administration equals F equals 1 or 100%. When drugs are given orally, bioavailability is usually lower because not all the drug is absorbed, and some may be metabolized before reaching the systemic circulation. A reduced bioavailability generally indicates either poor gastrointestinal absorption or significant pre-systemic metabolism, also known as the first pass effect. Clinically, bioavailability helps determine the oral dose needed to achieve the same therapeutic effect as an intravenous dose. First pass effect. The first pass effect refers to metabolism of a drug before it reaches the systemic circulation, resulting in a reduction in bioavailability. Let's follow the pathway of an orally administered drug. After swallowing, the drug enters the gastrointestinal tract. It is absorbed through the intestinal wall. It enters the portal vein. It passes through the liver, where metabolism may occur. Only the remaining unchanged drug reaches the systemic circulation. Because the liver metabolizes part of the drug during this first passage, less active drug reaches the bloodstream. This explains why some medications require much higher oral doses compared with intravenous doses. An important exception involves rectal administration. Approximately 50% of rectally administered drug bypasses the portal circulation, while the remaining half still travels through the liver. Therefore, rectal administration only partially avoids first pass metabolism. Drug transporters. Drug movement across cell membrane is not controlled solely by diffusion. Specialized drug transporters also play a major role. These transporters regulate the uptake and efflux of drugs from cells and influence drug absorption, distribution, and excretion. One of the most clinically important transporter is P-glycoprotein or PGP. P-glycoprotein is widely expressed throughout the body, including the intestinal epithelium, renal proximal tubulus, bile canaliculi, and blood-brain barrier. Its primary function is to pump drugs out of cells, acting as a protective mechanism against toxins and foreign substances. As a result, PGP reduces intestinal drug absorption, enhances drug elimination, and limits drug penetration into the brain. Several important medications are absorbed of P-glycoproteins include digoxin, etoposide, paclitaxel, tacrolimus, cyclosporin, apixaban. Drug interactions involving P-glycoproteins are clinically significant. For example, P-glycoprotein inhibitors such as many macrolide antibiotics decrease drug efflux, causing higher blood concentrations of P-glycoprotein substrates and increasing the risk of toxicity. Conversely, P-glycoprotein inducers, including rifampin and St. John's wort, increase transporter activity, lowering drug concentrations and potentially reducing therapeutic effectiveness. In oncology, some tumors overexpress P-glycoproteins, leading to multi-drug resistance because chemotherapy drugs are pumped out of cancer cells before they can exert their effects. Besides P-glycoprotein, two major transporter families are important. The ATP binding cassette or ABC transporters, which mainly export drugs out of cells, and the solute carrier or SLC transporters, which generally transport drugs into the cells. Distribution. After entering the bloodstream, drugs undergo distribution. Distribution is defined as the movement of drugs between different body compartments, including their target tissue. Major body fluid compartments include plasma, interstitial fluid, intracellular fluid, and transcellular fluid such as cerebrospinal, pleural, and peritoneal fluid. Drugs may also accumulate in tissues such as fat, skeletal muscles, and brain. The extent of distribution determines both the onset and duration of drug action. Factors affecting drug distribution. Several factors determine how rapidly and extensively drugs distribute throughout the body. These include physical and chemical properties, drug characteristics such as lipid solubility, degree of ionization, pKa, molecular weight. High lipid soluble drugs generally enter tissues and cross cell membranes more easily. pH of body fluids. The degree of drug ionization depends on the surrounding pH. Only the non-ionized form readily crosses biological membranes. Therefore, differences in tissue pH influence where drugs accumulate. Plasma protein binding. Binding to plasma proteins limits the amount of free drug available for distribution. Only unbound drugs can leave the bloodstream and produce pharmacological effects. Tissue binding. Some drugs accumulate within the tissues such as bone, fat, and cardiac muscles. These tissues serve as drug reservoirs, prolonging drug action. Regional blood flow. Highly perfused organs, including the brain, heart, liver, and kidneys, receive drugs rapidly. Poor perfused tissues such as fat receives drugs more slowly. Drug transporters. Drug transporter proteins, including P-glycoproteins, also regulate tissue penetration and elimination. Plasma protein binding. Many drugs circulate in two forms: bound drug, free or unbound drug. Acidic drugs primarily bind to albumin, whereas basic drugs mainly bind to alpha-1 acid glycoprotein. The bound drug remains in the bloodstream and is pharmacologically inactive because it cannot cross cell membrane. The free drug is active. Only free drugs can reach target tissues, produce therapeutic effects, undergo metabolism, and be eliminated. The degree of protein bindings depends on the drug concentration, binding affinity, and available plasma protein concentration. Certain clinical situations reduce protein binding, for example, hypoalbuminemia, saturation of binding sites, competition between highly protein-bound drugs. These situations increase the concentration of free drug. Although increased free drugs may enhance therapeutic effects, it can also increase the risk of toxicity. Fortunately, increased free drug is often eliminated more rapidly, helping restore equilibrium. Volume of distribution, or VD. Finally, we come to one of the most important pharmacokinetic concepts, the volume of distribution, abbreviated VD. Volume of distribution is defined as the apparent volume into which a drug distributes throughout the body. It is calculated as VD equals amount of drug into the body divided by plasma drug concentration. Remember that VD is not an actual anatomical value. Instead, it's a theoretical value that helps us understand where the drug resides after administration. In some cases, VD may greatly exceed total body water because drugs accumulate extensively within tissues. For reference, total body water in a typical 70 kilogram adult is approximately 40 liters. A small volume of distribution. A small volume of distribution, generally less than 0.04 liters per kilogram, indicates that the drug remains mainly within the bloodstream. This usually occurs when drugs bind extensively to plasma proteins or are too large or too polar to leave the vascular compartment. Large volume of distribution. A large volume of distribution indicates that most of the drug has moved into the tissues such as fat or muscle. Only a small amount remains in plasma. Consequently, the measured plasma concentration is low, making the calculated distribution volume appear very large. Drugs with a large volume of distribution often requires loading doses to achieve therapeutic plasma concentrations rapidly. Finally, diseases affecting the liver or kidneys may alter plasma protein levels and change the apparent volume of distribution, particularly for highly protein-bound drugs. To summarize, bioavailability measures the fraction of drug reaching systemic circulation. Intravenous administration provides 100% bioavailability. First pass metabolism decreases oral drug bioavailability. P-glycoprotein is a major drug efflux transporter affecting absorption, elimination, and drug interaction. Distribution describes movement of drugs between body compartments and depends on the drug properties, blood flow, protein binding, tissue binding, pH, and transporters. Only free on-bound drug is pharmacologically active. Volume of distribution estimates the extent of drug distribution into tissues and is an essential parameter for determining drug dosing and understanding pharmacokinetics. These pharmacokinetics principles form the basis for rational drug therapy and are essential for safe and effective prescribing in clinical practice. Now, let's move to the next page, continuing volume of distribution. As I mentioned before, volume of distribution, or VD, is not a true anatomical volume, but rather a theoretical value that describes how extensively a drug distributes throughout the body after entering the bloodstream. An important concept is that the volume of distribution changes with age. In elderly patients, body composition undergoes several physiological changes. There is a decrease in total body water and lean muscle mass, while body fat increases. These changes influence how drugs distribute within the body. As a result, hydrophilic or water-soluble drugs have a smaller volume of distribution because there's less body water available. Lipophilic or fat-soluble drugs have a larger volume of distribution because they accumulate in the increased fat stores. This means that the lipid-soluble medications such as diazepam may remain in the body longer in older adults, prolonging their effects and increasing their risk of adverse reactions. Therefore, dosage adjustments are often necessary in geriatric patients. Drug depot. Now let's discuss drug depot. A drug depot is a body compartment where drug molecules are stored and then released slowly over an extended period of time. Fat tissue serves as an excellent depot for high lipid-soluble drugs. Examples include diazepam, THC, the active component of cannabis. Because these drugs accumulate in fat, they can continue to be released even after administration has stopped, producing prolonged pharmacological effects. Drug depot can also be created intentionally using specially formulated medications. Examples include depot metroxyprogesterone acetate, administered intramuscularly every 3 months for contraception. Dipot-risperidone, given approximately every 2 weeks for long-term management of psychiatric disorders. These formulations improve patients' compliance by reducing frequency of dosing. Drug barriers. Now let's examine biological barriers. Drug barriers are anatomical or physiological structures that limit or regulate the movement of drugs into specific tissues. One of the most important examples is the blood-brain barrier, or BBB. The blood-brain barrier is formed by tight junctions between capillary endothelial cells and the astrocytes surrounding cerebral blood vessels. Together, these structures protect the central nervous system by preventing many drugs and toxins from entering the brain. Another important barrier is the placenta, which separates maternal and fetal circulation. Besides physical barriers, the body also possesses physiological transporter systems such as P-glycoproteins, commonly abbreviated as PGP. P-glycoprotein function as an efflux pump, actively transporting many drugs out of cells and reducing their absorption or tissue penetration. When prescribing medications, clinicians must always consider whether a drug can cross these barriers. For example, drugs crossing the blood-brain barrier may produce desired CNS effects, but can also cause sedation or central nervous system toxicity. Drugs crossing the placenta may expose the fetus to harmful effects, making drug selection during pregnancy especially important. Therefore, understanding biological barriers help predict both therapeutic benefits and adverse effects. Metabolism, or biotransformation. After absorption and distribution, drugs undergo metabolism, also called biotransformation. Drug metabolism is the chemical transformation of drugs within the body. Its primary purpose is to convert lipid-soluble compounds into more water-soluble molecules so they can be eliminated efficiently by kidneys or bile. The liver is the principal organ responsible for metabolism. However, metabolism also occurs in the gastrointestinal tract, lungs, plasma, kidneys, and many other organs. Drug metabolism can produce several different outcomes. First, an inactive prodrug may be converted into an active medication. Examples include tamoxifen, which is converted to endoxifen, codeine, which is metabolized into morphine. Second, one active drug may be converted into another active metabolites. For example, diazepam is metabolized into oxazepam, which also possesses pharmacologic activity. Third, metabolism may generate toxic metabolites. A classic example is acetaminophen, which produces the toxic metabolite NAPQI. Normally, NAPQI is detoxified by glutathione, but overdose overwhelms this protective mechanism and leads to liver injury. Finally, metabolism often converts active drugs into inactive compounds that can be safely excreted. An example is acetaminophen being converted into acetaminophen glucuronide. Drugs metabolizing pathways. Drugs metabolism occurs in two major phases. Phase 1, reactions. Reactions involves oxidation, reduction, and hydrolysis. These reactions introduce or expose polar functional groups on the drug's molecule. The result is only a modest increase in water solubility. Important phase 1 often prepares the drug for phase 2 metabolism. Most phase 1 reactions are mediated by the cytochrome P450 enzyme system, commonly abbreviated as CYP450. These enzymes are located primarily in the smooth endoplasmic reticulum of hepatocytes, although they are also found in the tissues. Products of phase 1 metabolism may be eliminated directly, metabolized further in phase 2, or occasionally become pharmacologically active. Phase 2 reactions. Phase 2 reactions are known as conjugation reactions. In this phase, the drug is combined with an endogenous molecules such as glucouramic acid, glutathione, sulfate, acetate, methyl groups, or amino acids. Conjugation greatly increases water solubility, allowing efficient renal elimination. Although phase 2 usually inactivates drugs, it can occasionally produce active metabolites. An example is morphine glucuronide, which retains analgesic activity. It is also important to remember that phase 2 reactions do not always require phase 1 metabolism first. For example, morphine can undergo direct glucuronidation. Factors affecting drug biotransformation. Many factors influence drug metabolism. Genetic polymorphisms. One of the most important is genetic variation in metabolizing enzymes. Individuals may be classified as poor metabolizers, intermediate metabolizers, extensive metabolizers considered the normal phenotype, ultra-rapid metabolizers. These genetic differences significantly affect drug response. For example, tamoxifen, tramadol, and codeine requires activation by CYP2D6. Patients who are poor metabolizers may experience inadequate therapeutic effects because they produce insufficient active metabolites. Conversely, ultra-rapid metabolizers convert these drugs quickly, increasing the risk of excessive drug effects and toxicity. Another clinically important example is warfarin, which is metabolized by CYP2C9. Patients carrying loss of function variant metabolized warfarin may more slowly, leading to higher drug concentrations and requiring lower maintenance doses to avoid bleeding complications. Enzymes inhibition. Drug metabolism can also be altered by enzyme inhibition. Many medications can also be altered by enzyme inhibition. Many medications and foods inhibit CYP enzymes. When inhibition occurs, metabolism decreases, plasma drug concentrations increases, bioavailability rises, and toxicity becomes more likely. For example, erythromycin, a CYP3A4 inhibitor, can increase blood levels of simvastatin substantially, raising the risk of statin-induced muscle toxicity. Another famous example is grapefruit juice. Grapefruit juice strongly inhibits intestinal CYP3A4, reducing first-pass metabolism and markedly increasing concentrations of many orally administered medications. For certain drugs, such as simvastatin, these interactions can dramatically increase systemic exposure, making grapefruit juice a clinically significant dietary interaction. To conclude this page, volume of distribution changes with the aging because of body composition changes. Fat serves as a depot for many lipid-soluble drugs, prolonging their effects. Biological barriers such as the blood-brain barrier and placenta determines drug distribution and toxicity. Drug metabolism primarily occurs in the liver and may inactivate, or produce toxin metabolites. Phase 1 reactions mainly involve CYP450 mediated oxidation, reduction, and hydrolysis. Phase 2 reactions involve conjugation, greatly increasing water solubility and drug elimination. Generic polymorphisms, enzymes, inhibitors, and even food like grapefruit juice can significantly alter drug metabolism and influence therapeutic outcomes. Understanding these pharmacokinetic principles is essential for selecting appropriate drug therapy, optimizing dosage, minimizing toxicity, and improving patient safety. Thank you for attending this lecture. If you have any questions, you can ask me in the comments. If you're new to the channel, don't forget to like and subscribe. Thank you for attending this lecture.